Okay, does everyone have the QR code? Can you grab that QR code or do you need the website? Here, let me get this out of the way. Trying to get this screen out of the way. There. Can you see it? Oh, some of you are already in there. Okay. And of course, I had to, no, I didn't. Never mind. Okay, so the correct answer is D3. So here you can see, and I know it's always hard because it's just hard to see decay in these projectors and when you try to clip pictures, but you can see the decay, clearly this looks to me like more of like a recurrent decay situation, but it's definitely hit the dentin. So you can see some shadowing under there. So that one's D3. The next question here. So where's my question? It says a D. Well, that's silliness. Okay, so what would you say what you're looking at is cervical burnout or decay by and large? I think. Just in general, when you look at through there, you just look at the different areas. Not to say there's not some decay somewhere, but just in general, would you say you're looking at widespread cervical decay or cervical burnout? Good. Yeah, cervical burnout. And sometimes it's tricky too because, we try to get pictures that are really clear. And sometimes the density of a picture, just the way like it comes up. So I like to pull pictures from Axiom because if I can save it nice and crisp and then get it in that way, sometimes it's easier to see. But it's even on in Axiom when students are taking pictures on patients, some come out lighter or darker. And so it can be kind of tricky so you have to just kind of use the things that you've learned about it and try to make your best guess. So which tooth has a restoration on it? This one should be easy. Yeah, so you guys should definitely start seeing, then that's not so subtle, but for some people who haven't looked at any kind of restorations, it can be hard. And next week, I'm trying to gather a case study so you guys can practice the odontogram some more based on decay and fillings, because that's an area that we tend to be weak in general. Even the seniors struggle with it, and the dentists always are hoping that we'll have more time to practice. So hopefully I'll get you guys something to practice in lab next week. Okay, so now I'm going to pause before we finish that up, and I'm going to do the PowerPoint here, and then we'll go back to that at the end. So today we're going to talk about periodontal disease. So this is like the intro of perio, but you remember, like an entire class where you're going to be learning just gobs and gobs of detail of perio. So this is taking a really complex topic, arguably one of the most important topics to dental hygienists. Like this is sort of like our area of expertise. So it's taking that topic and it's trying to distill it enough so I can teach you radiology, how it compares to radiology. So it's really tricky because it leaves like a ton of unanswered questions and feeling like it's just not like satisfying, but it's just trying to get that radiography part of it. And then you're going to fold in tons and tons of more information. But we'll just do, get those baselines down. So we're going to list and explain the limitations of radiographs when it comes to looking at bone levels and diagnosing, list and explain benefits of radiographs for interpreting and diagnosing periodontal disease, describe the difference between horizontal bone loss and vertical bone loss, so different ways that bone loss can manifest itself, explain the distribution of periodontal disease. And this also goes, for like gingivitis, localized versus generalized. I don't know if that's been touched on yet in Sarmiento's class. Compare and contrast the severity of periodontal disease. So we just look at the different stages and grading. That's quite complex of a topic, and it has a lot of shades of gray. So the staging and grading you'll learn much more about, and you'll apply it heavily in your senior year, but we'll just touch on it today. And then compare and contrast a healthy periodontium with disease. Sometimes it's really tricky to determine if you're looking at bone loss or a healthy periodontium. So you really have to, if all you have is radiographs, which is not normal, like you're not going to just have radiographs. You're going to have a patient in your chair who you've been probing and you've visually read their gingiva. You've looked at their gingiva and you've seen the marginal redness. You've seen the bulbous papilla. You've seen, you felt the spongy texture. You have probed and you've sunk down past a 3. You've seen some bleeding come. Like all of these things come together and you're like, oh, I see a diseased mouth as opposed to a healthy mouth. And so all of those things come together. But when all you have is a set of radiographs, you have to just ask yourself a few questions. Do I see the lamina dura? Where's the bone in relation to the CEJ? So you have to ask yourself like a series of questions, and and that's what we're going to talk about. Because honestly, it's like sometimes I feel like we're just arguing about semantics because it's like 2 millimeters of bone. Well, what does 2 millimeters look like? It's hard to say. So you have to kind of rely on some other things until you can see that full picture with the patient in your chair. So identify calculus and radiographs as well as other factors contributing to periodontal disease. So we'll talk about calculus and overhanging restorations and things like that. So the limitations of radiographs. So I've said this like a million times in this class, but we're taking a 3D object and we're making it a 2D image. So all of the depth of the whole skull is compressed into a flat image. So that's why we're layering landmarks, we're layering anatomy, we're layering teeth cusps, your buccal cusp over your lingual cusp. Like we're just layering everything. And it's the same thing for some kind of a bony defect. Is very rarely does it drop in this perfect, like the floor has dropped out from under us, like smoothly, like an elevator going down a shaft. Very oftentimes it's more like crags of a mountain, and it's like you've lost some bone here, and now you've lost even more here. And it's like this jagged, crevice and stuff. It's not always like perfectly flat from the facial to the lingual, from the mesial to the distal of that alveolar bone crest. So if we get a really nice picture with really good paralleling technique, we might say, oh yeah, that looks like some pretty flat horizontal bone loss. But most often, a lot of times we're not getting the full picture. That's why we need our probe and everything like that, because it could look one way when it's really another way. Yeah.
Do we only have to know past the localizing technique? Or classes, like only the ones, the what things we went over.
Oh, what I recorded?
Yeah.
It would behoove you to have listened to it and understand it. I think you'll feel a lot better after Wednesday. Because Monday group, do you guys all feel better about the localizing technique? I think you'll feel better after Wednesday. Because I have a worksheet and a quiz. And it like kind of like drills it into your brain. So, but it does, I think if you watched that, I think it's like 20 minutes. I think if you listen to that, it would help. But I think you'll feel in general just more confident about it after Wednesday. Yeah. Okay, so other limitations of radiographs for perio. So it doesn't show exact morphology of the bone. That's basically what I just went on about for a few minutes. Does not show disease activity. So, and this is like logical, but sometimes we have to say logical things out loud and think about them for a second. But a radiograph is a snapshot in time. So it's like when you're, in Italy and you've been like arguing with your significant other and you're exhausted and the vacation's not as fun, but you smile and take a picture and post it on Facebook and everyone's like, oh, they're having so much fun. But really you're like, ah. And so it's kind of like a similar thing. Like you cannot see the activity of the disease on your radiograph. All you see is where it's at. So even if the bone level is still high, there could be raging infection and you just haven't seen the floor fall out. So it's a snapshot in time. And that's why it's really important to kind of understand your patient's scenario. So did they have periodontal disease really active in their 30s and 40s, but now they're in their 60s? And what you're seeing is a reduced periodontium, but they're actually healthy. I mean, that could be a case. Like they have wonderful oral hygiene. Their tissue is very firm. They keep up on the biofilm accumulation, but they have this reduced periodontium because they did have bone loss at one time. So is it that, or is it they're actively losing bone? And so that just kind of summarizes, you can't see the activity. Never substitute for a clinical periodontal exam. Kind of feel like I've said that in a number of ways already. Does not show very early bone loss or early furcation involvement. So if furcation involvement is bone loss between the roots, and if it's just starting, it's just like very, very early decay. Oftentimes you can't see it on a radiograph. You can feel it with your probe, but you can't oftentimes see it on a radiograph. And then if a tooth is mobile, like you can look at a radiograph and if you've had experience, you go, oh my gosh, that tooth is probably flapping in the breeze. But obviously you can't see movement on a radiograph. So that kind of goes without saying. So, but the benefits of radiographs is that they will show bony changes over time. So if you take a consistent style of radiograph, you will see those changes. You'll see the decrease in bone, or you'll see if bone graft was successful. So periodontists and oral surgeons, they'll do guided tissue regeneration or they'll do bone grafts. And you can see that bone fill in if they've had surgery. So, you can mark those changes with a series of radiographs. Tooth and root morphology, so the anatomy, the curvature, the landscape, you can see that with different angles and you can see it with different types of radiographs too, like CBCT scans that show more 3D anatomy. Widening of the PDL. So, the periodontal ligament space is radiolucent. And one of the first signs that something's kind of going on is you get a widening of it. And so it'll look bigger. And you can get that down at the apex, and that could tell you that there's an abscess forming. You could get it up at the top near the alveolar crest, and that could tell you that something's happening there. It could also be that the person has ortho or something. It could also be that they clench and grind. It's not always perio, but it's one of those clues, one of those first little clues. Furcation involvement, you can see that as they get larger, abscesses, local factors that you'll be tested on that term. And I feel like people get it wrong a lot because it doesn't stick. So I try to emphasize it. Local factors are biofilm, calculus, overhanging restorations, space in between your teeth where food gets caught. Those are local factors. And then pathology, just the disease process. periodontal examination is incomplete without a full set of x-rays. So that's what we have to try and educate our patients. We don't want to x-ray them to death. We don't want to take them when they're not necessary, but it's you can't have a complete clinical exam and find out all you need to find out if you don't take a complete set of films. So you'll see this x-ray again, but just notice the difference between this top and bottom PA. So, we take our PAs and our FMX, and this is a premolar image, but just look at the bone level here on the mesial of 13, as opposed to down here. Like, just look at how distorted the bone is. It's just a nice, like, you just get a feeling that, okay, this is an accurate level. And now there's all of this kind of distortion where it's pulling the bone down to an area that looks lower. So it makes it look like there's more bone. Now, what you're seeing is you're seeing buccal lingual, you're seeing walls of the bony defect, but you're not seeing it in a way that will help you diagnose or understand the morphology. So you're not getting an accurate image. So even though you cannot necessarily see, the walls of the defect here, at least you get a more accurate image of where the bone level is. Not necessarily, the whole landscape of it, but at least where it is. So this is a far more accurate image for understanding your patient's periodontal disease. And then bite wings are a really, really good X-ray, and we've talked about this already for finding bone level. And that's why I harp so much. And your class, I've certainly harped on it more. You've practiced it more because every year I'm like, okay, I know that by the time you take vertical X-rays, it could be your senior year. You could go all next semester without taking vertical bite wings. But hopefully, once you see a patient and you have to take verticals, all of it will come flooding back. That's my hope. So that's why we've taken more vertical bite wings. But just here is this happened in senior clinic when I was filling in last week. One of the students took this it wasn't this picture, but it was like this. And this is what the patient needed. And it's not like it's their fault. They don't have that repetitive experience. So one of the first things that you need to ask yourself when you have a patient and you've realized their perio is, what kind of x-ray should I take? And then go back and look, like, what did they take before? And even if they took horizontal x-rays, you can override that and be like, they took horizontal, but you can't see the bone level. So I'm going to take vertical because that's what a clinician who's critically thinking would do. But that's just such a perfect example. And it happens, it just happens. We get busy, we get kind of overwhelmed by this new patient experience. But that's what we want to try and remember. And here's just another example. We get foreshortening and elongation, and it's just such a clear example of how the bone level gets distorted when we're angled. So when we use our vertical angulation, which sometimes we need, that's why an FMX is so great, because your bite wings are nice and parallel. Maybe sometimes your angle will be truer, and then other times your angles are just really off, and you're just using it so that you can see the apex. And when you put all of the pieces together, you're seeing hopefully the full picture. Does that make sense? Because you can't always take a picture that looks like this, even though this is better diagnostic. Sometimes you just end up with this, and that's just the way it is. So it's not like this is necessarily wrong, but it's just not as ideal. So if you're really trying to find bone level, you want a more parallel technique, X-ray, as opposed to bisecting technique, essentially, is what I guess I could summarize all that as. Okay, radiographic interpretation. So the definition of periodontal disease, peri is around the tooth, a group of disease that affects tissue around the teeth. So all the little connective tissue fibers, the collagen fibers, the fibroblasts, the bone, all the things, and you'll learn about all of them in perio. But all of that it's the foundation of the tooth. So your tooth itself could be marvelously healthy, but if the foundation is crumbling, then that's a bad thing. The CJ, you guys know the cemento enamel junction. It's the junction between where the enamel ends and where the cementum begins. And you can't really tell always where that is. And I don't know if you've had this, but you know how the CEJ can either come together, it can be gapped, it can be overlapped. There's different ways the CEJ can come together. Has that been a thing you talked about? I never know where you're at with the stuff. But so CEJs vary, and you can't always tell 100%, but in general, we kind of look for some of that information as a clue. Alveolar crest, that's the bone visible between the teeth, usually is pretty close to the CEJ. So in a healthy mouth, the alveolar crest, the bone should only be anywhere between 1.5 and 2 millimeters below the CEJ. It could be close, it could be just a millimeter, and you guys can visualize a millimeter because you have it on your probe. So it's really tiny. So the bone should be really close to the CEJ, maybe 2 millimeters max. And so that's the first thing. But measurements can be hard. Like figuring out exactly where the CEJ is and then seeing the bone and then saying, okay, I guess that's 2 millimeters. Is that 2 millimeters? I don't know. Get out my probe. It's not like what's the word? Like calibrated, right? Like the size of your probe and the radiograph are not calibrated. So it's hard to know for sure what's 2 millimeters. But you can say, okay, well, this bone is quite close to the CEJ. But one of the biggest things is you can look at the alveolar crest and look at the shape of it. It's very sharp. It's smooth. This is very blunted. It's smooth. So shape is a big aspect of it. Posterior, flat and smooth. Anterior tends to be a little bit more pointy. So those are a couple things that you can use. Then you can look at the lamina dura. So we know the lamina dura starts at the top, it goes over the alveolar crest, and it goes all the way down around the roots. And it should be fairly visible. Like not to say on everyone it'll stand out, not to say on every radiograph it'll stand out, but in general, your lamina dura you should be able to see it. And like back here, in these pictures, you can really see how the lamina dura follows the alveolar crest here and in this weird blue picture. Just stands out more in this radiograph. But I mean, you could see it. It really stands out. So that's another clue that you're like, whether or not I know for sure that's 2 millimeters of bone below the CEJ, I know the lamina dura looks nice and smooth and the bone in general looks smooth. So dense radiopaque line around the roots, periodontal ligament space, radiolucent line between lamina dura and the root, continuous and uniform. So it's, if it's kind of continuous, it's not getting wide in one area. Generally speaking, that's another clue. So you kind of use all those clues to help you if all you have is a radiograph. Evaluation of the periodontium, location and condition of the alveolar crest, lamina dura, periodontal ligaments, is it visible or widened, local factors, overhanging margins of restorations. So you're gonna look at the restorations on the teeth and the margins and see how smooth or not smooth they are. Sites of food impaction. So is a contact really open and wide, or do the contacts look pretty standard and like close together? Presence of calculus, can you see calculus? And then occlusal trauma, is there a lot of wear? The teeth very flat? Are they cupped because there's so much like wear, and maybe there's other factors like GERD or acid erosion? So here's a couple more pictures of healthy periodontium. And sometimes we lose some density too, so that like here, this image has lost density. So somebody might say that looks like bone loss, but it's just the way the picture was clipped and it was put on the computer. So we do our best to bring in pictures that you guys can look at for practice, but really the best images will be the ones that you take on your live patient, and you can use other information to back up. But in general, if we look more toward the posterior region, we can see a pretty thick lamina dura. Here as well, pretty smooth. Here, this might just be a density. It looks a little bit like the lamina dura is thinning here, but that could also be a density issue. So sometimes it's just hard to tell. Diseased periodontium. Now, it's easy to tell very diseased periodontium on a radiograph. That is like a no-brainer. Where you guys will struggle is mild perio. I struggle there. If all I have is a radiograph, I'm like, and so I lean heavily heavily on lamina dura, PDL, kind of try and guesstimate the space as best as I can. This is like nobody would look at that and think that person had healthy teeth. So you're not going to struggle in this class with identifying advanced perio on a radiograph. And the way when I'm testing you, if it's a 3 or a 4, and we'll talk about those classifications in a little bit, I accept either because it's like you just need other information to be definitive about whether it's a 3 or 4. So but you can see a lot of things. You can see very moth-eaten bone. You can see it well below the CEJ. You see local factors such as calculus. You see radiolucency between the roots. So you see furcation involvement. That's all pretty obvious, right? When you're looking at that picture on this side over here. And then when you look at this vertical bite wing, it's even more obvious, right? I mean, there's like massive bone loss, massive furcation involvement. I mean, you could drive a truck through that. I mean, it's like open. And the huge amount of calculus. So that it's not going to be hard for you guys to look at an x-ray pretty quickly and go, oh, there's periodontal disease there. And especially if you see other things like local factors. So this slide is like a summary slide. So I probably should have put it in the back after we went through all of this, but for some reason I put it in the front. But this is basically a summary of all the different sort of elements that you're going to put together for periodontal classification. So there's lots of things, just like with caries when I'm like, location, classification, severity, this is a similar thing. So the first thing is the amount, like how much perio. Is it localized? Is it literally on one tooth? Did they fracture a tooth or is there some kind of parafunctional abnormality or did they, get food stuck and it just started a reaction? And, is it just one tooth or a few teeth or is it like the whole mouth? And so you just want to figure that out. So we're basically talk in terms of localized and generalized. If it's less, then I have less than or equal to, but I think I might have that mixed up. Have you guys talked about localized and generalized? So is it less than 30 and then equal to or greater than 30? Okay, so sorry, I do have that mixed up. Something told me that was wrong. So I'll change that little sign. And I'm glad you know. So if it's localized, it's less than 30. If it's generalized, it's 30 or greater. So that's just sort of like a one descriptor. We're going to say it's generalized. We're going to say it's localized, and then we're going to give more information. And then these bullets are talking about the kind of bone loss that we see. So do we see generalized, horizontal with localized vertical? See how you can like switch up the terms just however you need to do it? Or is it just horizontal generalized or localized vertical and nothing else with the horizontal bone loss? It's just some localized vertical. So it just depends on what you see. And then furcation involvement, you can say if you see it on a radiograph, it's an automatic 3 or 4. But if you add your clinical evaluations, you could have furcation class 1, things like that. But if for this class, if you see furcation, it's automatically stage 3, 4, because at that point, the bone loss has gone so deep that it's just automatically that. And then moderate severe ridge defect is stage 3, 4. So that's just the amount of bone loss. Basically, when we're thinking slight, moderate, severe, we used to say that a lot before we would say the staging and grading. It was slight bone loss, 1 to 2 millimeters of loss, moderate bone loss, 3 to 4 millimeters of loss, and then severe bone loss, 5 millimeters or greater. A lot of this is really challenging to figure out if you don't have a clinical exam. And these are the overall staging and grade, or not grading, but just staging. So stage 1, slight to mild. Coronal third, so it's just the bone loss is only going to be in that part. So if you take the roots and you divide it into thirds, this bone loss obviously will be within that coronal third, that top third. And it's got to be less than 15% of the overall bone. So it's not very much. So it's 1 to 2 millimeters of bone loss. It's not very much. Stage two is still in that coronal third, and it can be as much as that full third of the whole length of the root. And then stage three is going to extend into the middle third. And then there could be some vertical bone loss, some furcation involvement, and then four, the middle third of the root beyond and beyond, including vertical bone loss, furcation, and mobility. So that's just gets worse and worse as we go. Yeah.
Define the percentage you take, the number of affected teeth divided by how many teeth the patient has. Can you get that percentage?
Um, you take like however many, or so if they have, 28 teeth in their mouth, if they don't have their wisdom teeth, and then however many teeth have some kind of bone loss around them. Yeah. And then you take those teeth and then you would divide it by the total number of teeth in their mouth. And then if that's 30 or more, then it's generalized. Math's not my strong suit. I can tell you the percentage, but don't ask me how to get there. I think, but that sounds right. Okay, so distribution is kind of how we classify this first one. The overall classification is staging and grading, and you'll learn way more about that. Pattern of bone loss, and then other things like furcation and ridge defect, and then the overall severity. We used to up until like honestly like 6 years ago, maybe we just would say mild, moderate, or severe perio. That was it. That's all anyone ever said. Mild, moderate, severe. And whether you thought mild was moderate or you thought moderate was mild, that's all anybody ever said. And it has been like pulling teeth, no pun intended, for people out in the world to go to the staging and grading. But now the insurance company recognizes it. And so there's much more like this is more normal way of talking, but it literally used to just be mild, moderate, severe. So like everything, we just made everything more complicated. Okay, so I'm just going to fly through a few of these. So localized, generalized. That's just giving an example, like a localized area versus generalized. Horizontal bone loss, the floor has dropped out evenly. It's like the elevator going down the shaft. It's just whoop, the floor dropped out, and that's horizontal bone loss. You're seeing a relation that's even to the CEJ. The bone level stays kind of even between the relationship between two teeth. Vertical bone loss is sloped. So we're going to see a vertical, it's not going to drop down evenly. It's one side's going to have more bone loss than the other. So that's your pattern of bone loss. I'm just highlighting some of those shapes there. Horizontal bone loss, for a little bit more for the pattern. So the alveolar crest should be less than 2 millimeters, for healthy, so 1.5 to 2 millimeters. That lamina dura is well defined. Hard to determine whether the disease is active or stable. But if your patient has been coming to you every 3 months, every 4 months, you certainly, as a clinician, whether or not they're active or they're stable. For vertical bone loss, you can see just different examples of it. Greater degree of bone loss in the interproximal aspect of one tooth compared to the adjacent tooth. So it's kind of sloped, may require surgical treatment to try to regenerate the bone. So a thing about vertical bone loss is it's in general a more severe situation. The person usually has more infection, it's more virulent infection. However, a vertical defect is easier to regenerate bone because you have walls or a scaffolding for the new bone to build into. Like if you just have a floor and you dump a pile of bone on the floor, it's like grow, but it won't. But if you have walls and then the bone can like fill up on the in the wall. So it's actually has more success in regenerating bone. But in general, it is more a severe state of infection. Okay, so back to the severity, slight, moderate, or mild, moderate, severe. The severity of bone loss is measured by the clinical attachment loss. And Professor McGee geniusly can explain all this to you, and she'll go into it in far more detail. But the CAL is your clinical attachment loss. So essentially what it is it's from the CJ to where the bone is. And that could be, like your clinical attachment loss could be less than your pocket depth, as is kind of shown here. The tissue's all bulbous and inflamed and comes up over the CEJ, or your clinical attachment loss can be greater than your periodontal reading, because let's say somebody has 3 millimeters of recession, but their periodontal probe reading's only 2 millimeters. So their clinical attachment loss is 5 millimeters, but that was probably hard to capture without a picture. But did that make sense at all? So like if you're probing and you're like 232, 232, 232, but your patient has like 3 millimeters of exposed root surface, you have to add that 3 to their pocket depth, like 2 or 3, whatever it is. So their clinical attachment loss is going to be greater than their probing depth. But in this case, where the picture is, their probing depth is greater than their actual clinical attachment loss. So it could be either or it could be the exact same. If the gum tissue is at the CEJ, it'll be the same. So it's kind of we don't have to harp on it in this class, but you'll hear a lot about CAL, clinical attachment loss. Okay. So classification, so this is you just have to have kind of a generalized understanding of this, because when I give you x-rays, I'm going to say stage this x-ray, and you're going to just do your darndest to do your best to figure it out. But so stage 1, slight, it's going to be in the coronal third, less than 15% of bone loss, and it'll probably look something like this. Very minimal bone loss. That's going to be stage 1 perio, very minimal. Stage 2, moderate, we're going to drop down into, we'll still be in that coronal third, but it's going to be that it could be anywhere in that coronal third. And so it could look as severe as this, but notice the furcations are not involved yet. The furcations are not involved. And then stage 3 and 4, for our purposes for this class, if the minute you see a furcation, shadow in a furcation, just put them at a 3. The minute you see a furcation. Now, one thing that you guys also might have learned about, though, is that the trunk portion of a tooth, someone could have a very long kind of trunk area, and then the furcation starts way low. And so really they have like, I mean, honestly, that wouldn't make, the minute they have a furcation involvement, they probably more like at a, 3 or 4 if they've lost that much bone. And then somebody else could have a very short trunk. I call it a trunk. I don't know if that's what you guys, if that's the term you guys learned, but that's what I was taught eons ago. But so before you come to the furcation could be very short. And so like they could have a furcation involvement and only still be in the coronal third. So it's not hard like line. There's that gray, which is challenging, but in general, I try to give you pictures where this makes sense. This staging makes sense. But just for your understanding, know that things are not cookie cutter. Everyone's anatomy is different. So just again, a lot of this is repetition. Well-defined alveolar crest within 2 millimeters of the CEJ. Stage 1, rounding of the alveolar crest. So you're going to start to lose a little bit of that bluntness, and some of the widening of the PDL is going to start to happen. And then they're going to lose a little lamina dura. And then as we go farther, it's going to start to get this moth-eaten look to the alveolar crest as we get more bone loss. And as we continue down the picture here, you're going to start to drop out of that. You'll maybe potentially still, if you're stage 2, you're still in that coronal third, but getting close to that middle third. E and F show far more advanced bone loss with some vertical bone loss and some furcation involvement in staging 3 and 4. So just continually goes down, gets worse. You guys want a break? Kind of maybe a good place to, because now I think we're just going to look at some pictures. So yeah, I'm going to print off your quiz for today. So let's take a 10-minute break. Then I'll pause this and I'll print off your quiz. And we'll finish this up here. So when we look at this picture, Obviously, if this is an extreme, you can see there's a lot of, you're well below the coronal third. And the way, one way you can kind of train yourself to do this is if you print out or if you have a iPad and you can pull up an X-ray on your iPad, just draw a horizontal line or as horizontal as it makes sense to be at the CEJ and then draw a horizontal line, find the apex, and then break it into thirds and just visually break those root lengths into thirds over and over and over again. And so you can start to just see it. It's the same thing when I talk to you guys about a horizontal overlap. Is it more or less than a third? You guys have gotten really good at it, but you still don't always get it perfectly. Sometimes you just ignore it when it's too much or you count it when it's too little. So you have to get that designation in your mind. Is it more or is it less than a third? And it's really the same thing with root length. Is that bone loss in that first third or is it into the middle third? And of course, if it's into the middle third and below, your mind should probably just go, okay, that's really advanced. So, but usually it's that early stage that's hard. It's figuring out something, little that's the tricky part. So you just have to practice it more, a lot of opportunities to practice. Sorry, my PowerPoint disappeared on me. Come back. Okay. So this is just showing the horizontal bone loss. So we have relatively flat. I mean, you can see there's definitely some, difference there. But in general, it's relatively flat. And then we have a furcation involvement, very wide open one. So furcation involvement, it's the loss of the furcation or bone in the furcation, poor prognosis for the teeth. If the tooth is not mobile and they have a furcation involvement, why do you think that would be a poor prognosis for the tooth?
If the tooth is not mobile.
If the tooth is not mobile, but they have a furcation, and it's not even like, let's say this one right here. Let's take this tooth here. Why would this tooth have a poorer prognosis than a molar that had bone, that maybe filled up to here?
Also, what is the loss of.
Yeah. Yep, exactly. It's all about cleaning. It's all about access and cleaning. So that's why, I mean, it's hard. It's hard for us to clean it. So you think the patient's going to be able to get into that little tunnel every single day effectively and clean out the biofilm? It can be done, but it takes dedication and it's really hard. It's hard for them to do. So it has a poorer prognosis in general. Like you don't tell your patient, oh, you're going to lose that tooth. It's like, oh my gosh, that tooth's going to fall out because they could keep it for years and years and years, but you do have to stress it's hard to maintain. So here's just more examples of furcation involvement. Can you guys see the furcation involvement on this tooth with the crown? It's probably impossible to see it on the projector, but if you see it in your computer, it's just barely starting to show radiolucency right there at the start of the furcation. And then obviously these are like wide open, so they're way easier.
You say this like a type 1 rotation on that round? Or
Well, you do when you're in clinic. So that's a good question. You absolutely do. And the way you do it is like with your probe, really, to start with. Like if you go along and you're probing and then you kind of run your probe in kind of a horizontal sweep, if you feel your probe like fall into a curvature, just barely, then it's like a class 1 furcation. But if you feel like you're going in any kind of depth, then it's class 2. But you can't tell that really from a radiograph. So we don't really classify furcations at all in this class, but you will for sure. Okay, so and the other thing too is when you're looking at the bone loss, so notice right here, notice how these CEJs are not even. Do you see that? How they're sloped, like right across these neighbor teeth, the CEJ is pretty equal, but the CEJ between this premolar and this molar is kind of sloped. So that can throw you. And to be honest, I have read sources that say if the CEJ is tilted and the bone level is tilted, that's not true vertical. But I've done enough research on it that I don't think that that's the way that we should think about it. So just look at the CEJs. They should, it matters, but honestly, not every tooth is going to be perfectly in line because people have all kinds of occlusal issues and teeth shift and teeth rotate and come in. So CEJs are not always perfectly across the board the same height. So still, look really at the end result. Like here, this is not severe bone loss. You can still see, bone back here. It's probably a multi-walled bony defect. But there is some, if I move this, I don't know. Oh, I can't move it because it's not the original. I'm looking at a screen. But if I move this, you can see there was an angle here, and then there was this more kind of light bone in the back. So there's some vertical. That's a hard one. I'd test you on something that was a little more cut and dry. But this one does have some vertical bone loss here, horizontal bone loss here, furcation involvement. And this is just giving you, looking at the long axis of the tooth, noticing where the CEJ is, and then looking at the bone and how it's been lost. What's the pattern of the bone loss? So local factors, that word local factors, there'll be an exam question that says, what local factors, blah, 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 and it'll multiple choice. So you have to know that term local factors that cause irritation. And sometimes they're a predisposing factor to periodontal disease. So if you have something an overhanging restoration that's collecting a lot of bacteria and you have it long enough and you don't take care of it well, and you just have that perfect storm of different things, then certainly it could be a recipe for bone loss. So these are some pretty horrible ones. This one is just, a huge overhang. Calculus is formed. There's, obviously a big bony defect here. Lots of calculus. We have open margins on these crowns. I mean, I just don't even know what happened here. I mean, it's obviously there's decay, but it looks like the crown was prepped inside the root, like instead of it meeting the root, it's like they put it over to the side. I don't know. Sometimes dentistry can be scary. And then on top of that, it could be bad dentistry, but then on top of that, their oral hygiene is probably going to be harder to have good oral hygiene, and then they might be just neglectful in general. So then it compounds it. But I mean, I don't see how anybody could take really good care of overhangs like that really in general. So calculus is that stone-like calcified plaque, essentially. Defective restorations, they could be open margins, loose contacts, poor contours, uneven marginal ridges, overhangs, and inadequate margins. Some more calculus, lots of calculus, wraps all the way around the buccal and the lingual. Cervical rings of calculus basically is what we would call it, around 8 and 9. Faulty overhangs, some more just giant overhangs. They're just, you're going to scale that and just come to a wall. You just hit a wall. And if it's a small overhang, you can actually smooth it in clinic, and you should. But if it's an overhang like that, the filling just has to be redone. Okay, so what do you guys see on this as far as local factors? Calculus, pretty obvious, right? You guys are getting keen eyes, really rough roots, really a lot of calculus, a lot of bone loss. Is it horizontal or vertical bone loss? Yeah, you got some vertical here. You could argue horizontal here. And again, we have same thing, calculus buildup, horizontal bone loss. It's kind of like concave. So when you look at this picture, what would you classify this patient as? Yeah, their lamina dura looks really good. You can see it potentially, maybe. I mean, the CEJ is here, so it's not a perfectly parallel shot, but from just what we can see, it looks fairly healthy. The bone level comes a little bit lower toward the back here, so there might be some localized, it's either just where their bone level is after like a third molar extraction, or there could be a little bit of bone loss. But in general, I would say they look healthy. Here you can see we got some more local factors. Got loss of the lamina dura, calculus. Again, loss of the lamina dura, looks moth-eaten, calculus, missing teeth, open margin on the crown, furcation involvement. So there's lots of things to pick up and see. Yeah,
So the mothing units 3.
you can see that early. It just means it's like I don't know if it's just my term or other people use it, but it just means like instead of that nice solid lamina dura that's nice and smooth, you start to get texture and you start to lose that lamina dura. So it doesn't necessarily mean 3, but it definitely means something's changing. So this is a retained baby tooth, and we really haven't talked about it, and I feel like we need to. So I feel like I should maybe I'll try and there's so many things I want to incorporate into next lab because we don't have class next week. Is it next week or no, the week after? Whatever Veterans Day is, I can't remember. Yeah, not next week. 2 weeks. 2 weeks. So there's so many things and there's not enough room to put it in. But we haven't really talked about the way baby teeth look on radiographs. But in general, you can imagine they look smaller. The roots are more spread out. They're shorter. So it's usually fairly easy to pick out a retained deciduous tooth because it just looks quite different. And this one just, there's obviously not as much root. So the bone loss is going to affect the tooth quicker. But that's what's happening here. On this one, we have overhangs, we have calculus, we have bone loss. If you were to guess, where would you stage this bone loss down here? Might be different up here, but where would you stage it down here? On the mandible, down in this bite wing. If you were to guess.
You?
I would probably say a 2. Yeah, we're probably getting up to maybe a 3 up here, but we lose a little bit of visibility. Now, one thing you guys can make note of, but really this application won't be until you get into clinic, but we stage in the area of the most severe disease. So literally somebody could have 2 teeth that are involved in pretty advanced perio and the rest of their mouth is not that bad, but we stage them according to the worst area. So that's hard sometimes for people because they're like, my patient doesn't look that bad. But if they have one area that's a stage 3, then they're a stage 3, even if the rest of their mouth is a stage, 2 or something like that. You're going to stage them to the worst. Okay, local factors, tons of calculus, lots of bone loss. You can look at this and say, and as you have experienced, this will resonate, but obviously this calculus is adding some stability. And so once that calculus is gone, you just know those teeth are going to be incredibly mobile. And that's what the calculus looks like in clinical view. So there's just, a lot, it's bridging or splinting. The calculus is like splinting the teeth. And so when you go to remove it and the teeth are hanging on by the root tips, they're going to be incredibly mobile. Now, you're not going to extract it. It's not going to be that mobile. Like people are always afraid to scale a mobile tooth because they're like, what if I pull it out? You might have to like kind of stabilize it and scale it, but you're not going to extract it. It's still held in there quite fairly well. But it'll move. It would absolutely move. And then, so we just look at the bone loss here. So in general, what would you guess this bone loss is? Yeah. In general, I feel like the level of bone loss is probably even closer to a 2, but you'd bump them up. If this was an exam, you'd bump it up to a 3 just because of that furcation involvement. And it's also looks a little bit higher up here. So some of these areas don't look that bad. They kind of look like maybe they're in the 2-ish range. But like here, that's probably maybe going into a 3. Up here, it's harder to see, but that might be more of a 3. And then we have this furcation involvement.
You had it at stage 3 and 4. What separates the 3 and 4?
So because we don't have that clinical aspect, we just say 3, 4. So that's the only time you will ever say that is in this radiology class because all we're looking at is radiographs. So we just don't have that full picture. So it's like 3, 4. I mean, you can say definitively a 4 if it's like that. Like you can be like, that's a 4. But in general, I accept I just give you a wider, like I'm like 3 or 4. So but what about this one? Describe the bone loss here. So describe it in a bone loss pattern, horizontal, and then probably somewhere in a stage 3, 4. Yeah. What about this one? This one's a little bit tricky because honestly, it this person is likely healthy. I mean, you can see their lamina dura. This one, it almost has a little bit of like a funky little texture, but you can still see the lamina dura. So sometimes, and like here and here, I think that's just a density issue. So I would probably, if I had to guess, I would say the person's probably healthy. However, if you got them in the chair and you started probing and they had a bunch of gingivitis and bleeding, then it's like, oh, all right, maybe they do start to have some very slight changes that we can make note of. But just taking this, it's very close. The bone level's very close to the CEJ here and here. I see that lamina dura. The PDL doesn't look overly, like large anywhere. So I'm going to go with healthy, even though sometimes you get some funky things on a radiograph.
Because
Back
that's
here.
more than, I guess, 2 millimeters.
From here to down in here. Like, are you looking at this little section through here? And so that could be clenching and grinding. Like I don't have any bone loss, but I do have some widened PDL. So what I would probably do is I would look at the lamina dura and I'd say it's really close in general. Yes, there's a little widening here, but maybe they hit heavy. Like maybe there's a parafunctional activity. So I don't want you guys in this class, I don't want you to overdiagnose. Like, and it's especially if you've had experience and you've looked at a lot of x-rays and talked with doctors, you could like you could start to go down thinking, well, maybe this and that and this. But we're just going to take it broad because you don't have all those pieces to make a full understand. That's what's hard about looking at just the x-rays is it's like, well, I don't know. Maybe that is a little bit of the beginning of widening PDL and bone loss. But I have other things that I can say this patient looks relatively healthy. And so I'm just going to lean on that. I'm going to err on the side of they're healthy because I don't have probings. I don't have clinical exam. So I know that that definitely can feel unsatisfying, but otherwise some people are going to say healthy and some people are going to not. And I kind of just want us to land on the same page. But I mean, I absolutely agree with you that I can see what you're seeing. I just don't know that that's bone loss. That is the unsatisfying hard answer about doing, perio at this stage with nothing else. Same thing here. We're starting this one. I could argue it's, again, it's like, is it a density issue with the radiograph? But you could argue like just by looking at it, you're like, well, I feel like that looks moth-eaten. Like this is clearly nice and smooth. There's no bone loss here, but you're like, but again, there is a lamina dura there. It's pretty close to the CEJ. It would be assumptuous to put them at a class stage 1 just off of this radiograph. It would probably be a little safer just to say healthy because we see, the bone levels close and we see lamina dura, and that could just be the density of the radiograph losing some detail. That could be all that it is. So we kind of err on the side of that's why in the notes it says healthy. And so I'm trying to show you some examples because this can be an area it's easy to pick out a stage 3, 4. It's harder to pick out a healthy versus stage 1. 2 is okay. Same here. Here again, we have lamina dura, that's looks pretty smooth all the way through here. Again, as we come up here, it's highly unlikely they have perio around their canine because canines are easier to clean. It's way more likely perio would start in the back. So, or between premolars at the very least. So this is again, an example of healthy. Here we have diseased, furcation involvement, vertical bone loss. And this is just that picture from before, just to remind you again about that direction of taking your radiographs. The more parallel it is, the better you can see the bone loss. We got vertical. So if this picture was something that you were tested on, you would say vertical between, oh my gosh, what is that? 29 and 30. You'd say vertical between 29, and you'd say furcation involvement between 30, horizontal bone loss between 30 and 31, and on and on. And so you would just, if I was asking you for a little bit more specific detail, you would go through and describe it like that. This one, again, it doesn't seem too severe, but you can see we're losing, it looks smooth, but we're losing some definition. So this one, you could argue it's a stage 2. Somebody might argue stage 1, but especially when we see where the CEJ is in the top of the bone, it's kind of dropping down. So it's probably closer to a 2, but it's also might have some vertical angulation to it. So we'll have some more practice opportunities. Sorry if I took that away too quick. We'll have more, no, come back here. We'll have some more practice opportunity. But what I do want you to start thinking about, because I know you guys always have so many different assessments in your mind, but what I do want you to think about is, oh my word, hold on, I have to fix this. It's going to record just my big face. Why does that go away? You have to get this up before we run out of time. Why did my screen go away? Why did all the screens go away? What happened? I didn't push any buttons. That's weird. Okay, well, I cannot share, I can't share my screen for whatever reason. It totally went black and I can't slide it over. But I want to continue on with that Mentimeter that we started with in class. So if you're still logged in, if you go back to your Mentimeter, I advanced to the next slide. I can't show it up here, which is bumming me out so bad, but I don't know how to do it because this screen like went away on me. But the next question, if hopefully you see it, or do you guys need the QR code again? Which I don't know how I would give you because I can't share my screen. Did you guys, can you get in, can anyone get in there? Because the next, here, I'll press present if it needs to be refreshed. Because the next question should say pin something. Okay. Hold on. Yeah, so pin the soft palate on the right side of the patient. This is really gonna bum me out big time because I want to show it. I want to point it to you guys. Why did it stop doing that? I have no clue. And I just don't have, I have like 10 minutes. So if I go to PC, I can see the screen, but the minute I go to laptop 2, hold on, let me try one thing really, really fast.
Somebody told me that this.
Oh my gosh, I fixed it. Okay. Okay, so the soft palette, so press enter to show the correct answer. So those of you who put your little pin in that area, that's the soft palette. So, and the person who did it over here, you're not wrong. You just got your right and left mixed up. So, and on the landmark exam, I'll have the arrow on the thing, and so then you'll have to type in soft palette. But this is one that sometimes people miss. And there's other things in this area, but this is the soft palette. Looks kind of like a tongue hanging off the hard palette. So, okay, so let's go to the next one. Pin the mental foramen on the left side. As I dribble all down myself. Okay, so I'll press, you guys, are answers still coming? So here's the area of the mental foramen in general where that the most of the dots are. So on the other side, you can see the mental foramen here. So that's on the right side here. And then on the left side here, the mental foramen. Okay, so pin the anterior nasal spine. So now it's hard to see it with all this, but it's not the straight line going up, that's the septum. So it's that diamond shape. So it's really the radiopaque area that's kind of, I mean, it doesn't look like a perfect diamond because it just looks like a radiopaque blob. But if you look at your skull, it's this, and borrow your skull. It's this right here. And so when you put it in 3 or in 2D and then it's got all of that bone that comes out and it flattens it. So, and that looks diamond shaped. So that's your anterior nasal spine. Some other things that you can see here is in general, our submandibular gland fossa is, see how it's more radiolucent in these areas down here? So that's our where our submandibular gland fossa is. You can see the nerve canal, the mental nerve, the mandibular nerve canal, where the nerve runs through there. Up here, we have the mandibular foramen up at the top, and then it exits at the mental foramen. Our our internal oblique ridge, sorry, comes down, and you can't really see it, but it would come down over the molars. And then our external is what we point at, just coming straight out of out from the posterior area. Um, Let me go to the next one. So on this one, pin the zygomatic process on the right side. So next week when we come into class, since it's week 12, we're going to do the landmark exam first. And that you get about 45 minutes for that. And then we have lecture afterwards. So just as a reminder. So the zygomatic process, I'll show you over here on this side since it's not all pinned up. But do you see this J right here? It was clear on the right. That's the zygomatic process that I want you guys to recognize. There's other parts of the zygoma, but basically right where the 7 is, they landed right over it. The J kind of comes right down in here. So that's the zygomatic process. Pin the condyle on the left side. Some background music. Good. Yep. So that's the condyle where this 20 is landing. That's the condyle. It drops down. We have the mandibular notch and the coronoid process. And the coronoid process is kind of hidden behind it's also kind of overlaid with that soft palate. But we have the condyle, mandibular notch, coronoid process. Okay. Pin the external auditory meatus on the right side. Do you guys notice any strange radiopacities through here? Did any of you see that? We got something going on there. Something weird. Don't know what it is. Not normal. Through there. Good. Yes. So up here, so you can see it over here. That's the external auditory meatus, the little black circle. Up by and then you can see soft tissue around here. Sometimes I think that's the styloid process, although I was trying to look for a panel with a good styloid process, and that's not great, but I think that's what that is. Okay, next one. Pin the area of the right coronoid process. Yeah, that is the styloid. It's a long one, actually. That's a really long styloid. Looks like an icicle. And you can see it over here. Actually, I should have made that a pin. Darn it. You got to know that, though. It's a styloid process. Pin the areas of the right coronoid process. Good. Yeah, so right in here, we got the coronoid process. Over here, we could see it as well. It's overlaid with that soft tissue. And then mandibular notch condyle. Pin the left mandibular notch. Yeah.
Corner process again.
Yes. So on this one, the coronoid process comes up here. It's kind of hidden back behind. It's layered. So the coronoid process is hard to see sometimes, but see how it's like a triangle? It's just behind the soft palate. So sometimes it's a little harder to see, but that's the coronoid notch. And then the mandibular notch is that swoop between the coronoid and the condyle. Down here, if I ask you for the angle of the mandible, it's going to be this. This is the angle of the mandible. And then this down here is the border, inferior border of the mandible. Pin the left hyoid. So if I asked you guys where the palatoglossal airspace is, where would you say? Can you see it on this x-ray?
It follows.
Right through here, right? So that's the top of the tongue. So it's between the tongue and the palate, even though their palate's distorted because their chin was up or down? Down. And then as we come, so where do you see any other air spaces on here? Yeah, so we have the nasal pharyngeal and then the oral pharyngeal as we come down. And see how they branch together? They connect. So the nasal pharyngeal is up here. You can just see that shadowiness. Everything's, you have to kind of like look in layers, right? Like you can't, you got to look through things sometimes to find other things. But if you kind of just look for the darker areas, we have the nasal pharyngeal through here and it connects to the oral pharyngeal. And nasopharyngeal, oral pharyngeal, and palatal glossal. Palatal glossal, though, is officially like an error, but it's still an airspace. But the nasopharyngeal and the oral pharyngeal are like always there because those are just your throat.
Palatable, they don't put their tongue.
Palatal glossal is when they don't put their tongue up because that's, yeah, palate and tongue, palatal glossal. Yeah. Okay. So, yeah, hyoid bone. Good job there. And where is the orbit? The right orbit. Someone's always got to be a rebel doing the left. Yes. Okay. We're essentially out of time. So yes, that's your orbit. Don't get it confused with your sinus. I'm going to sneeze. Thank you. Okay. I think that might have been the last one. Let me see. Yes, that was the last one. Hope that helped. Little refresher. You're going to have about half panos, half PAs on the landmark exam next Tuesday. So study, study. In the Moodle, of course, there is Quizlets with lots of pictures. So there's lots of resources available. You just have to look at them. Okay. Thank you, guys. Good luck on your next class. Whatever's coming up. Tooth ID.